So, hi all, it's an honor for me to introduce Srikant Sarangi, the second keynote speaker of the conference on caring discourse, conceptual, ethical and practical challenges to the shared decision-making paradigm. Thanks a lot for taking part in this virtual edition of Caring Discourse. So now let me introduce you Srikant Sarangi. He's professor in humanities and medicine and director of the Danish Institute of Humanities and Medicine at the Aalborg University in Denmark. Using an applied linguistic perspective, Srikant conducted interesting researches in the context of institutional and professional discourse, dealing with various topics that include but are not limited to communication in generic counseling, telemedicine, palliative care, intercultural pragmatics in multicultural societies. On this and other fascinating topics, he published 12 books, more than 250 between books, chapters, and journal articles. And finally, let me add at least that he is the editor of Text and Talk, an interdisciplinary journal of language, discourse, and communication studies, and the founding editor of both Communication and Medicine and the Journal of Applied Linguistics and Professional Practice. So today, his talk is on shared and unshared decision-making in healthcare encounters, a communication ethics perspective. So please, Srikant, the floor is yours.
Thank you, Maria Gracia. I don't know what it means to take the floor.
In this case.
But it's lovely to try this out. Let me begin. I think it would be nicer to have more of a question answer, but I hope that would happen on the 15th when we discuss. So I will raise various issues as I talk through this title. And actually, I'll begin by unpacking the title a little bit because I see there are 4 different aspects to the topic: the clinical, the cultural, the communicative, and ethical. Not everything can be unpacked now, but I thought it would be useful to at least open up the different dimensions of shared, unshared decision making. But also in my title, I talk about SDM, shared decision making in healthcare delivery, but healthcare is too broad and unhelpful. So what is shared and unshared decision making will have very different significance in different settings, in primary care, in geriatrics, in genetics, in chronic illnesses, palliative care, end of life, something that I will come back to at the very end. So we really can't talk about SDM in healthcare. That's too broad and too vague. Let me begin by picking up the 2 words shared and decision. And both the concepts are pretty slippery, communicatively, interactionally speaking. In many institutional professional settings, the notion of decision is always dispersed or even elusive. One doesn't even find it when you look through your transcripts or texts. In fact, in healthcare settings, the word decision is hardly used explicitly. People talk about other things, alluding to problems, options, choices, preferences, consensus, solutions, rather than decision. So how do we locate, identify where is the decision in the interaction in the clinic, even before we ask whether it was shared or not? So just like decision is elusive, but of course there are different ways in which people conceptualize what we mean by decision making. There are 2 dominant paradigms as I see them. One is what might be called the cognitive heuristic bias based on experience. That's the Nobel laureate Daniel Kahneman. The fast thinking and slow thinking, how people take or make decisions intuitively based on experience, both professionals and patients, but again, with different outputs. The second paradigm is more rationality, logics, algorithm, usually associated with decision aids or decision support systems. So that's where we can think about the rationality based as opposed to the intuition based decision making. So what we mean by decision would be pretty nuanced before we come to shared and unshared. There is a huge amount of confusion around terminology and definitions. So I suggest we can begin to appreciate what is shared by juxtaposing it to what might be unshared. So that would give us some kind of a clarity as to what it is not rather than what it is. Then we have another concept that comes in, which is what is referred to as informed decision making rather than shared decision making. So how do practitioners and patients know that a decision is shared or unshared or informed? That's question number one. Question number two, how do we as researchers identify what counts as shared decision making? How do we identify and locate it? And how is it different from shared information sharing, and shared understanding? So shared information, shared understanding, and informed decision and shared decision. As you can see, there are many competing terms that we need to navigate through to understand what is it that we want to look at when we engage with empirical data. What I'll do today is mostly focus on the communicative and ethical aspects of shared. Now I'm putting shared in inverted commas. How is a shared decision accomplished interactionally or communicatively and ethically? And that's something what I am calling the communication ethics perspective. Metaphorically, and I know many people like metaphors, I'm going to focus on three things. At the conceptual level, I'll talk about the holy grail of SDM. That's metaphor one. Then I'll try to talk about communicatively the black box. That's metaphor two, the black box of SDM. And the third metaphor is relating to the ethics. It's the walking the tightrope of SDM. And I think this more or less in line with the conference theme, how can we explore the conceptual, ethical, and practical challenges in caring discourse? So let's begin with the holy grail of SDM. Very basically, SDM is about giving patients options and choices while safeguarding their autonomy. So in other words, it's the patients who make decisions rather than the doctors or the clinicians, and therefore it's an ethical matter because it deals with autonomy. I think one way of capturing this is SDM can be called, following Richard Weaver, it's a God term. You can't negate it, you can't deny it. But what makes it problematic is there are other God terms bordering on SDM: patient-centeredness, patient autonomy, professional neutrality, professional non-directiveness. So we are basically in the midst of many God terms that we have to adopt and use. But despite its godliness, there is skepticism. I think I am reminded of the Dutch philosopher Anne-Marie Moore, who talks about that giving people options doesn't necessarily mean there will be better outcomes. So options may be abused, may be misused, may not be understood. So we can't assume that every patient is capable, has the decisional capacity to make and understand what is being talked about and make that decision. She also talks about what she calls the illusion of choice. So we'll see later in a few minutes that when we talk about decision making, it boils down to giving people choices, options, so that they can weigh up different options and decide what is best for them. But there might be an illusion in the sense that the choices may not be equivocal. The choices may not be real choices. So you might say, you take this medication or you die. That's not really two choices. So how do we weigh up and assess that the choices have some kind of a symmetry, some kind of a balance? So that could be equally problematic, in addition to the level of literacy and decisional capacity of the patients. SDM is not a new concept in clinical practice. I can go back to more than 60 years when Stas and Hollander talked about 3 different interaction models of doctor-patient communication. The activity-passivity model, which is very much the paternalistic one, drawing on the power between like a parent and a child. The second model is what they call guidance and cooperation, which is typically what you expect, that people seek advice and get advice. You go to see a doctor because you have some advice to obtain. And the third model is what they call mutual participation. And this means the doctor and the patient on equal terms. And the patient takes responsibility. And I think that is going more towards SDM. So in a sense, we're talking about mutual participation. If you look at mutual participation as key to SDM, then it is basically a way of moving away from a paternalistic model. So that's the passive patient and the active doctor, the first model. It also marks a shift from moving away from rationality-based decision-making, particularly economic rationality. So the more we foreground participation and involvement, we're really talking about a complementary role relationship between the patient and the doctor. In other words, the doctor and the patient are both experts. And that's the kind of a movement we notice these days with the concept of the expert patient. The patient is an expert. But patient expertise and patient participation can still be identified in interaction without it being shared decision making. So there is no clear one-to-one relationship between patient participation, involvement, and expertise and a decision being shared. Let's go back to a classic book by Tuckett and colleagues in 1985, and the book was called Meetings Between Experts, which assumes that the patient is also an expert and the doctor is an expert. So there are 2 experts who meet in the clinic. But what they highlight in this book is that there is the very likelihood that there might be a gap in competence between the doctors and the patients. And therefore, shared understanding may not be possible. So we can talk about 2 experts meeting in the clinic, but actually the assumption we make that they're experts and they share the competencies may be questionable, may be contentious. So basically, we can say, what does shared decision making underpins or assumes? That it means that there should be two parties who are fully engaged in the process of deciding, also sharing emotions, feelings, values, and information, having mutual respect and a caring attitude, but also having mutual expectations about each other. And then we are really talking about informed decision making rather than shared decision making. Another framework to think about shared decision making comes in terms of the patient power from a continuum from the low level to the high level. So as you can see in this slide, at the lower end, we have paternalism, which is basically information giving mostly by the doctor. Interestingly, shared decision making comes in the middle way, and informed decision making actually is the patient being empowered maximally, optimally. So shared decision making still implies or is still closer to paternalism rather than informed decision making. So what does it take from for clinic encounters to move from a paternalistic, where the patient has less power model, towards informed decision making, and that means overcoming shared decision making as well. There are many models of SDM, and the one that is very much cited is by Charles and colleagues back in 97, revised in 99. Interestingly, they say that there are 4 principles. It must involve at least 2 people. Both parties must take active steps in the process of decision making. They must participate. Information sharing is a prerequisite. I think that is a very crucial aspect of shared decision making. How much of information is shared before a decision is shared. And finally, a decision is made and both parties agree to it. I think it strikes me this very last principle, a decision is made, which is a passive form, which means who makes the decision is not clear in these principles. And as I'll come to sharing some empirical work, actually a decision is usually made by the doctor and then shared, rather than a shared decision made together at the same time. So it's not a tango as they would expect. Then they go into various stages, and they are very similar things. These are stepwise. I won't go through these in detail, but basically I just put them for discussion if people want to come back to this when we get to discuss the paper. Similarly, other people, such as Braddock and colleagues, talk about the similar things, that how there should be discussions about the roles, the clinical issue, alternatives, choices, benefits, and risks, and different types of uncertainties, which is very important. But equally important is patient's understanding and the exploration of the patient's preference. The one that is far more simplified is Glenn Olvin and his colleagues talking about 3 steps of SDM. Step 1 is what they call choice talk, that patients know what reasonable options are available. Step 2 is option talk, that there is more information about the options that should be considered. And step 3 is decision talk. So this is when we consider the preferences and decide what is best. I think this seems very neat as a model, but it's very difficult to separate what is choice and what is option and where is decision happening. But even if we are able to talk about choice and option as 2 different types of talk, we might find that these talks are usually controlled and triggered by the physician rather than the patient. So for instance, the choices are laid out by the doctor. So already there is some kind of a limitation to what the choices are. When we talk about options and providing more details, again, it is the doctor who gives all the details. And those details can be very persuasive, unethical, or biased. So in other words, it's very difficult to come to a point where you could say that the choices and options were also shared, so the decision is shared. So there are very, very huge question marks about how such models actually can be operational in real life encounters in the clinic. Equally, we must remember that much of the discussion is about treatment decisions rather than about the whole patient lifestyle and the patient outcomes and patient care more generally. So SDM is about decision making with regard to treatments and interventions rather than the whole of the consultation. But what about patients' desire or preference for SDM, including resistance? So in other words, people might have very different types of preferences in regard to how much doctors know about the patients, how doctors disclose treatment discussions or choices, like I said before, how much of the treatment decisions are laid out. Maybe the clinician's hands are tied at the back. They can't give all the choices because of the constraints, the managerial constraints, the rationalities of the economics, but also how the treatments, the choices are selected. So that's a very complex and nuanced issue conceptually. Now let's very quickly move to the communication side and open the black box of shared decision making. How do we see SDM accomplished in interaction? Is it a shared decision? Or, as I have said in a recent paper with my colleague, it's more like a decision shared rather than a shared decision. Let me come to that. As interactional communication researchers, we might ask a number of questions, and our interest might be, how do we spot or locate SDM in interaction? We might talk about involvement or participation, such as active listening, how the agenda is set and expectations are shared, aligned, how topics are managed, medical, life world, and so on. What's the role of questions and answers, whether questions are opened and closed, who initiates questions, how much of patient narratives is facilitated, negotiated, who gives explanations, how information is packaged, how is advice given, and what kind of roles people occupy as educator, as therapist, as being committed to social justice and fairness. So all these things might be useful to look at the interactional level. So this is a study we did in the context of genetic counseling. And we suggest that, yes, there are some steps, and they neatly can be formulated into some kind of a model. Here there are two first steps where the problem is formulated and then confirmed or owned by the patient. It has to be before we can talk about options. Then we generate potential options, but they have to be evaluated, each option against others. Then a decision is formulated and it has to be evaluated and adopted by both parties. So if we say that there are these 6 steps, 2 dealing with problems, 2 dealing with options, and 2 dealing with decisions, it still doesn't tell exactly how this is manifest at an interactional level, who initiates and who responds to what extent. So the sequential manifestation of the model is far from neat and clear and structured. So that's something we need to think about when looking at the different models of SDM at the clinical interactional level. Could it be that a decision is first made or formulated or even hinted at, nudged by the healthcare provider, and then offered to the patient and family for approval or agreement? In that case, we may have to make a distinction between decision shared versus shared decision. There are many other scholars, particularly in conversational analytic tradition, talking about other terminology, such as they don't use the term shared decision as such, but much more participatory and non-participatory decision making, or bilateral and unilateral decision making. But my point is simply that qualifiers such as participatory, non-participatory, bilateral, unilateral still can take us closer to decision-making patterns or trajectories, but it dispenses with the term shared. Here is another interesting study by Robertson and colleagues, who say that actually patients participate to a great deal in primary care consultations, but actually that participation doesn't mean the decision is shared. So patient participation, they argue, can lead to minimization of resistance and generation of consensus. So it could be unethical in that sense. It could be persuasive, because at the end, the decisions are not shared because the decision is usually left to the biomedical experts, that is the clinicians. Likewise, in end-of-life consultations, Barton and her colleagues talk about consensual and non-consensual ways of arriving at decisions, and they clearly point to what might be unethical persuasion. So some persuasion is ethical, some are not. In the context of genetic counseling, it is not about making decisions, a wise decision, but about making a decision wisely. The process is more important than the outcome. So there is no shared decision as long as the process is shared and the decision is still by one party. So doctors can find themselves as partners in the conversation, but they can also be like salespeople trying to impose a particular goods, a particular thing that is preferred. So imposed versus informed decision making, and this is Carnielli Miller and Eski Votis talk about how doctors in the talk are already becoming marketeers of treatment options, of emphasizing particular benefits of certain treatments, why the timing is perfect. So all this can be very persuasive and imposing. And coming to the close of this part, in the genetic counseling context, Elwin and colleagues talk about moving away from being non-directive or neutral to shared decision-making. So shared decision-making is a better option than being non-directive or neutral, because being neutral and non-directive can border on indifference in terms of clinical and ethical recommendations. But they tell us immediately that SDM may not be applicable in all genetic counseling consultations, given the complexity and uniqueness of cases. I think a similar point I have made, that it is very difficult to balance non-directiveness, neutrality, and client-centeredness, which is inclusive of SDM. So all these empirical studies are basically hinting at the ethical dimension of shared decision making. And I think my last point is that the ethics and communication cannot be separated. SDM lies somewhere between the doctor being unilateral, paternalistic, to being a salesperson and persuasive. So it's a middle ground, but it has elements of both being paternalistic and being persuasive. So this is where we can talk about ethics, that the decision, any decision is about self in relation to others. So the self and the other here, it could simply mean the professional and the clients, but can also mean the patients and other family members and so on. So let's get to the final part about the ethic. What does SDM mean in ethical terms? And these are some points that I will not go into in detail, simply to flash them out and might be worth bearing in mind. Where is decision made? What is the front stage and back stage? Sometimes decisions are made not in the clinic at all, but outside of the clinic, both by the patients and by the clinicians. So where do we look for decision making and shared decision making? What's the balancing between public good, the social good, and the patient's best interests? So this is about the individual versus the societal. What about health economics and the rationality principle? Much of decision making in hospitals and clinics are determined by health economics rather than anything else. COVID-19 is a good example of how decisions are totally unshared and driven by the economy rather than anything else. What about patients' rights versus best interests? Because patients may have rights, but the doctors may know what is in their best interest. So it is not the same thing being exercising one's rights, being a consumer, being autonomous, but not knowing what might be in your best interest. As I said, the patient versus the family, the differences within the family, as in palliative care and end of life. So shared decision is not about provider and patient, but it can also be about patient and family, or family versus family. And can SDM sit comfortably with the principle of do no harm? So what happens if a shared decision is doing more harm than good? What does the doctor say in such context if the patient wants to exercise their right and be responsible for the decision? A very useful paper by Loris Kaljian a couple of years ago, where he talks about shared decision-making in relation to unshared decision-making, can only be understood with a bigger canvas landscape of what he calls goals of care. When we come to this concept of goals of care, there might be very different goals which may not be shared between the doctor and the patient. So the goals are impinged by health beliefs and values, and these are already in the relationship between the doctor and the patient and the consultation before we talk about interventions and treatments. So there are possible discrepancies or disconnects between the clinician's goals, which might be guided by biostatistics and biomedicine, as opposed to the patient's goals, which might be a prioritization of immediate well-being, patient's preference for autonomy, whereas clinicians' concerns for patients' best interest or beneficence. So there might be already some kind of a hiatus between the doctors and the patients about the goals of care. And if the goals of care are not shared, then a decision about treatment and intervention is far from being shared. I want to conclude this part by a very useful reflective piece that I published in Communication Medicine some years ago by a physician who is giving a narrative, a reflection about his dealing with an end-of-life consultation between different family members and their wishes. And he somehow admits that his decision aligned with whichever family member he was talking to, rather than exercising his clinical judgment. In other words, the decisions were very different depending on whether he was talking to the son of the dying patient or the daughter of the dying patient. And the son and the daughter had very different agendas and very different goals of care. And in a commentary to this piece by Michael Brannigan, he talks about how SDM then becomes the sacrificial lamb that can be sacrificed in favor of aligning with a particular family member at the expense of another. So in other words, these are very ethically sensitive matters. So that is where communication and ethics must be brought together in talking about shared decision making as well as shared understanding. I have been trying to suggest shared understanding is very crucial, in fact, a precondition to shared decision making, because health literacy and decisional capacity must be a precondition for informed or shared decision making. The ethical aspect is the more we talk about speech acts and communicative acts, they are ethical acts because they always have implications for others and it always implies role relationships. So every speech act is a communicative act and by extension, an ethical act. And this is where we can talk about whether we are acting communicatively or strategically. It's the very classic distinction that Habermas talks about communicative action and strategic action. Whereas communicative action is regulated or guided by rationality and consensus, intersubjectivity and validity claims, strategic action is usually influential and persuasive. So to me, it seems shared decision-making in many instances are examples of strategic action rather than communicative action in Habermasian terms. So we need to look at communication ethics in terms of ethics and morality within a particular cultural social space. And that has to be in relation to trust at the bottom, the mutual trust, expectations, and well-beings. Then we have the autonomy, the rights and choices that are the sphere of the patients and the families, but also tied to the choices and rights and autonomy are role responsibilities. So just a couple of slides to conclude. SDM is not easy to characterize. It's not a bandwagon we can join and simply, float along, both ideologically, but also communicatively. I also don't believe that any consultation is either SDM or paternalistic in their entirety. So there are phases in the consultation where it has to be paternalistic and where it is always shared decision making. So these are not consultation types. These are just different aspects of a consultation. Just like one cannot say a healthcare professional either fits into the SDM or the paternalistic category. Equally, it is very simplistic to label patients as active or passive holistically. Sharing information rather than sharing decision must include discussions about risk versus benefits, but also risk versus risk. The decision ultimately has to be the patient's responsibility, whether it is shared by the clinician or not. I think for me, SDM implies the sensitivity to the context of the encounter and the tolerance of variability and being somehow actively involved in the patient's life world. But that often can mean that professional neutrality might be compromised. might be sacrificed. In this sense, SDM is not only a shift away from paternalism, but also a shift, potentially a shift away from evidence-based medicine, thus undermining the epistemic authority of healthcare experts. In embracing SDM, there is the inevitable risk of throwing the evidence baby with the paternalistic bathwater. And this remains a challenge for healthcare professionals to simultaneously orient to evidence-based practice, the scientific mentality, and accomplishing shared decision-making or patient-centeredness. I think this is a classic struggle that's not going to disappear. How does one go beyond the individual good so that decision-making often is undertaken at the societal public good level, and most physicians bear that in mind. Of course, there are many cultural variables that we haven't talked about here today, which has very little studied empirically. But it's worth reminding ourselves that in a culturally, linguistically diverse population, healthcare population, health literacy is one issue, but just literacy is another challenge. Because in such diverse linguistic, cultural, healthcare delivery situations, contexts, talk itself might be the problem. Therefore, sharing of information and shared understanding cannot be presumed, cannot be taken for granted. So rather than subscribing to shared decision-making in a blanket form, we may ask, where is SDM crucially relevant? Where should we be thinking of SDM much more foregroundedly? I think I would suggest where there is uncertainty. So in situations of uncertainty, in terms of diagnosis, treatment, prognosis, like in genetic counseling and many chronic fatigue, many chronic illness contexts, such as chronic fatigue syndrome, cancer care, and so on, we can talk about shared decision-making because these are uncharted territories. There are lots of uncertainties, and shared decision, shared information is absolutely crucial. As opposed to where there is high level of certainty, there may not be a need for shared decision-making. Also, equally important is where human values, dignity, quality of life, such as palliative care and end-of-life consultations, where shared decisions are very important because there is a medical failure that medicine can do no more. In such situations, uncertainties and quality of life issues, there are choices to be made, and these choices have to be formulated and negotiated through a shared agenda. So just to capture that last point, that we have here two axes. One is the uncertainties, the horizontal axis, and the consequences of decision-making, the vertical axis. So what I'm trying to suggest through this is when the uncertainties are low, then medical intervention can be straightforward. But as we move the uncertainties to a higher level, there are psychological aspects and ethical, socio-moral aspects. Therefore, the consequences of the decisions are much more in the psychological, social, and moral sphere, where shared decision-making might be the best possible option. So in other words, it is not a one-off, switch on, switch off kind of a scenario, but a gradient that we need to appreciate and apply and use our judgments to see where and how shared decision-making might be relevant, might be feasible. Thank you.